but thank you for doing so. I don't know if this is a little bit, the title's a little bit provocative maybe. What I'd like to talk about in this outcome section is how we, what do we mean when, what do we talk about when we talk about recovery? What do we mean when we say recovery? And how do we measure it? So if we go back to the beginning, from the website, one of the goals of enhanced recovery after surgery are to get evidence into practice, to integrate us from our different silos from surgery, anesthesia, nursing, and the patient's perspective. And also another important aspect is to decrease some of the unwanted variability in care between different practitioners. Those are all very important goals. And on the website it says this is designed to achieve early recovery for patients undergoing major surgery. So if we want to talk about recovery, I think we'll start at the beginning. We'll go to the dictionary and we get a definition of what does recovery mean. The definition dictionary is that recovery is the act of regaining or returning to a normal state. So we're going to break it down a little bit. So first of all, it's an act. So what this means is we're going to use the term recovery because it's an act as opposed to the term convalescence, which means I sit back and I convalesce and things happen to me. Recovery is an active process that patients engage in. It's an active process. It's not a passive thing, so it's an act. And the next thing is, of course, the second aspect is that it's returning to normal. And the implication there is that we need to know what normal is if we're going to return to it. And so the implication there is that we need to know what happens at baseline, or if we don't, or if things are not normal at baseline, we need to know what's normal for that population, for example. The third issue in measuring recovery, and we saw this picture of Dr. Moore, who's yesterday we saw the same picture, same Google picture. I guess it must be #1 Google image on Dr. Francis Moore, who's a giant in American surgery in the 20th century. So the third aspect of recovery is complicated. It's a complex and multidimensional process. And I think his definition of convalescence, which I'm using to mean recovery, is probably the best definition, which includes all the interlocking physical, chemical, metabolic, and psychological factors commencing with the injury, and terminating only when the individual has returned to normal physical well-being, social and economic usefulness, and psychological habitus. The patient will always carry the scar of his injury, and in that sense, he may never be the same again. So I think we've got all of the elements that I think I'd like to bring out. And if we look at the logo, and this has been commented on a couple of times in the past day or so, we look at the logo. I'm going to start with that and try to use this to discuss some of the concepts. So when you look at the logo, it has a lot of the things that we've just sort of mentioned. It has something that starts over here that's kind of normal, and then we have something that drops, and then it returns back to normal. And the hypothesis of ERAS is that whatever it is that's dropping is not dropping as much in the ERAS group, and then I guess the slope is the same because it then gets back to normal at a different time. So what I'd like to ask you is, what's on the y-axis and what's on the x-axis? And what those questions are is basically, how are we measuring recovery and when are we measuring it? In order to answer this question, I think it depends on your point of view and your stakeholder position in the process to understand a little bit about when you're measuring it and what you're actually measuring. And there's one way to look at recovery that's often used is that there's overlapping stages of recovery, early, intermediate, and late. And the early phase is defined as from the operating room to the discharge from the PACU, and that happens in a matter of hours. It's generally an anesthetist that's in charge of this part of the process. The outcomes that we're interested in, and I'll show you how we can classify these, but in general these are physiologic and biologic outcomes. And the threshold we use to decide if the person is recovered is based on safety, so that they're safe to go to the floor, they're conscious, and physiologically stable. Intermediate phase of recovery is from when they leave the PACU to when they leave the hospital, and that happens over a period of days. The outcomes that are probably most interested in this time period are classified as symptoms and impairments, and the threshold is something like self-care, so the patient is able to care for him or herself at home. And then there's the late phase, which starts when the patient leaves the hospital and finishes, as I mentioned, when the patient, or as Dr. Moore mentioned, when the patient returns to their usual function and activities. That can take months. And the way that generally we would suggest it's measured is by things like functional recovery, functional outcomes, and quality of life and the threshold is what we're looking at is if return to normal. If we look at the stakeholders, patients in qualitative studies equate recovery with the absence of symptoms and return of their ability to perform activities as they could prior to surgery. So that means patients define recovery as what's happening in that late phase. So how do we define recovery? As we've seen this slide a few times, the primary outcome in the majority of randomized trials, at least, and I agree completely with what's been said about, randomized trials aren't the be-all and end-all, but they are the be-all and end-all in most meta-analyses, at least quantitative ones. And the primary outcome is length of stay. It might be complications, but I'll just talk about length of stay a little bit. So if we look at that as being the most common primary outcome, then the y-axis is clearly days in hospital. And the x-axis is a measure of something that keeps people in hospital, which I think we'd all agree is a difficult thing to quantify. People try to quantify it. So we can get people out of hospital faster with care pathways in general. And as we heard this morning, the way we're doing that maybe is by not doing harmful things that we know, evidence-wise, are harmful, and by standardizing what we do. We know that if we avoid doing bad things to people, and we do it in a systematic way, and we agree in a consensus how we're going to do it, then we can get people out of hospital faster. And what we end up doing there is that we're making the in-hospital part of the recovery, at least in North America, where we're having 3 or 4 day length of stays, we're making that in-hospital part of that late phase of recovery a smaller and smaller part of overall recovery. So I'd like to talk a little bit about what happens when patients leave the hospital. And basically, we can send patients home almost to a certain extent whenever we want to, in a way. And what happened where I work, and I think it happened in a lot of different places, is that we started to do ambulatory surgery for laparoscopic cholecystectomy, as an example, which of course now is completely normal thing to do. But if we go back 15, 20 years ago, we started doing laparoscopic cholecystectomy. The patients were admitted the night before. We did the operation. We kept them a day. And so they had a 2 day length of stay and 1 day before the operation. And what happened in our province is that we had a virage ambulatoire, which meant that hospitals and units were closed. And we could not do that anymore. And we did things like stop giving patients morphine, and we sent them home the same day. And now, of course, we send all the patients home the same day, but it wasn't to improve recovery or just something that we could do. But when you look at what happens when patients get home, and if you use some of the outcomes that we've talked about, this is using a questionnaire that patients report on their physical activities that they do, and we can get an overall estimate of what they're doing every week. We could see that if you look at high-intensity activities, they were not, on average, back to baseline a month after the operation. This is lap chole. This is nothing, right? And I think it's always useful, I guess, to have a model of what we're trying to study. And this is a nice model that Franco and Nancy Mayo from McGill have published. And I think it's extremely useful to frame the discussion. So if we have surgery and, of course, a stress response to surgery, which results in short-term changes and impairments. So changes, inflammatory, endocrine responses that result in pulmonary circulatory changes, and patients have impairments or report symptoms and have symptoms of pain, fatigue, and we can measure weaknesses. And there's something about these things that are somehow related to length of stay, and of course they are. And I mean, the length of stay is important. I'm not saying it isn't. I'm just saying that we're using length of stay as a surrogate for these things, as well as complications and other things, but we are using it as a surrogate. And if patients ultimately are interested in this box here, in long-term outcomes, reintegration, quality of life, we also know that there's very little evidence that links these impairments to how long it takes to do this. Very little evidence here linking these things. But there is evidence that links these short-term impairments to these sort of in-between outcomes, the functional ability of the patient. So their activities, their mobility, and there is data that links these outcomes with longer-term integration and quality of life. So I'd like to argue that we should, when we're doing studies of things like that are designed to improve recovery, that we might want to focus on developing these outcomes and looking at these outcomes. And we already heard a bunch of things that obviously we're interested in this, where we work, about the things, simple walking tests, as used as a measure of functional walking capacity. You can do a little short version of this, a 2-minute walk test. You can do that in hospital and measure that every day and see and compare it to baseline and see when it normalizes. You can show that we all know that important things that impact recovery are things like complications, and we can show that, like I said, recovery is very complicated and has a lot of factors that impact in it. But you can use these kind of, because it's a number, you can, and it's an interval number, unlike quality of life scales, which are an interesting discussion, because in quality of life scales, what it means to be a 4 or very good is not necessarily 1 better than what it means to be good, or 3, but in something like how many meters you walk, each interval is equal to the interval before it, so it's easier to do math on that. Or questionnaires, like I mentioned, self-reported questionnaires that look long and complicated, but essentially we ask patients to define the activities that they do, and we give them a list of about 40 of them. And then they tell us how long they do it. We know on average how many metabolic equivalents are expended with each of those activities, and we can get an overall number per week. So what I'd like to do is just look at the outcomes that are used in ERAS studies to reflect recovery, and kind of get a sense of maybe where we might want to focus some efforts in developing outcomes and validating outcomes. So this is a study that one of our fellows is doing, and it's not published. And the study will include randomized and prospective studies. We've heard many times, there are many excellent cohort studies that do a very good job of trying to get at some of these issues. But as an example in here, I'm just going to look at the randomized trials as an example of these 49 papers that we found to do this systematic review. I'm just going to do that just as an example to make my point. So all of these studies, and I commend everybody, and many people who worked on these studies are here, and they have my full and utter admiration for getting this work done, and it's so vital. The primary outcome, as we said, in most of the studies is length of stay. And most of the studies of this nature are very short-term, look at things very short-term. To classify outcomes, we're going to use a conceptual model of health-related quality of life from Wilson-Cleary. And in this model, if ultimately we're looking at quality of life, the model suggests that, and it's similar to what Franco's biological model of recovery is, and it's based on this model, it says that downstream things like physiological and biological variables have an impact on the things moving upstream, but these things also have other things that impact them. For example, functional health is dependent on muscle strength, but it also depends on your environment and other factors. And as you go up the scale, those things get to be more and more important, and it gets harder and harder to measure these things. So if we look at just in the studies, in the 9 randomized studies, physiological and biological variables are reported in vast majority of studies, mostly in terms of GI, time to bowel movement, to time to gas type of thing. 80% report some symptoms or impairments, and in that category I would put symptoms about nausea and vomiting, or did I tolerate a diet, and I'm not exactly sure what tolerate means. Did they walk independently, the time that they walked independently. And then things a little bit more objective, or much more objective, things like measuring muscle strength with grip strength or leg extension. Only 3 studies mention any functional health outcomes, and these are getting more quantitative, including one study using a pedometer. This is actually the first randomized study from 2002, or a diary talking about the time that they mobilized. And 2 studies reporting quality of life using a variety of pretty standard measures. And most of these studies are focusing on the very short period. And just as an overall synthesis, physiological and biological variables in general are faster. Symptoms and impairments were less, including muscle strength, which was better preserved with the enhanced recovery pathways. And for our functional health outcomes in hospital, more time ambulating and more steps in all the studies. Now let's look at 30-day outcomes in 5 studies that reported 30-day outcomes, and there were no differences in any study. No differences in fatigue, and Andrew showed us that this might be an issue with the measure that's used, but this is a standard way to look at fatigue, These are, and as I mentioned, this is a subset, but just as a general idea, no differences in fatigue, no differences in pain, no difference in one study using HADS, depression and anxiety, and no difference in quality of life using a variety of measures. Where there is a difference, the only other 30-day outcomes that are reported, besides readmissions and complications, are muscle strength. And in the 3 studies that looked at muscle strength, these were better preserved with enhanced recovery after surgery pathways, which is very exciting, really. And not very surprising that, I'll take you through this, but not very surprising that things like health-related quality of life may not be different, but things like functional outcomes, like activities and physical activities, may be a better way to look at things. And Franco showed a little bit of this data from, this is I think a landmark study about recovery of functional recovery after abdominal surgery, looking at a variety of measures and how they recover repeatedly over a 6-month period. And these are elderly patients after major abdominal surgery. And I've rejigged the presentation of the data, but basically, if you look at quality of life measures, and you look at the green is when they get above baseline. The funny thing about quality of life is that sometimes the operation is done to improve quality of life. If they have symptoms of obstruction and they're relieved, then their quality of life goes down briefly with the surgery, but then it's going to go up above baseline. Unlike for functional activity, which is going to go down and then go up to where it was before. Now, I'm not talking about getting a new knee and that it should go up even higher. And if you look at things like quality of life, they actually are above baseline. Mental component summary scale of the SF-36 is above baseline by 6 weeks. And for physical component, it's above baseline by 3 months. At 3 months, it was above their baseline. So it's not surprising that quality of life may not be the way to look at the success of these programs. If you look at activities of daily living, the more interesting, not the basic activities of daily living, although these were surprisingly took in elderly patients 3 months to get back to baseline, and weren't above baseline even at 6 months. But the instrumental activities of daily living, shopping, housekeeping, and so forth, were not back to baseline until 6 months after surgery. So things like physical activities, and when we look at impairments in muscle strength, grip strength, very simple to do, was still below baseline at 6 months. So basically measures of activity and performance take longer to recover after surgery. And just to give an example of whether this might just be a more sensitive measure of what we're trying to measure by enhancing recovery. I took a bunch of studies that have come out of McGill where we used 6-minute walk test and defined recovery as getting back to baseline. And looking at the patients who are within that measurement area that Larry said, the 20 meters, between the different studies we measured different places, but let's say around 6, 7, 8 weeks after surgery. Traditional care, open surgery, this is from a study of PCA versus epidural. Only 30% of patients after colorectal surgery were back to baseline at 6 weeks. In the first prehabilitation study that Franco talked about, that didn't work very well. We still have now mostly open surgery, we've done a little bit of exercise before, and there was no enhanced recovery pathway, didn't budge, 30% back to baseline at 6 weeks. Now, we started to get better when we did a couple of things. We went to laparoscopic and we introduced an enhanced recovery after surgery pathway. Now we're at about 60% who are back to baseline at 6 weeks. And finally, with Franco's new and improved trimodal prehabilitation with laparoscopy and enhanced recovery, the last data we have are that 80% of patients were back to baseline at this point at postdoc. So my conclusions about measurement of recovery is that it's complicated and it's a difficult thing to measure. Different dimensions are going to require different measurement tools. And that, in general, not an apple pie, but that when we do studies, obviously we should pick instruments that have shown to be valid, or that there's evidence for their validity in the context of measuring recovery after surgery. So that's the construct. And I think we need a lot more information to understand, like Andrew said this was a problem, knowing what the minimal important changes, let's say for surgical recovery score, to be able to power studies appropriately. Finally, I think there are a few studies, and we've heard about this, looking at patient-centered outcomes after discharge. And I think I've hopefully raised awareness about things like quality of life. That might not be our best outcome, to capture these changes that are occurring, and that outcomes like functional capacity and performance lend themselves to this model of recovery where we measure something at baseline, it goes down and then goes back to normal. And intuitively better reflect the preservation of muscle mass, which I do think has been demonstrated with these programs. And I think this well encompasses the challenge of measuring this nebulous construct, which is that everything that can be counted does not necessarily count, and everything that counts cannot necessarily be counted. I want to thank all the contributors to this work.